Over to you, Bob.
I'm Robert Teasell. I'm a professor and PM&R specialist at Western University and Parkwood Institute in London. And I'm going to be chairing this session on virtual reality and stroke rehabilitation. As you know, VR or telerehabilitation was just slowly starting to get developed and integrated into our system when COVID changed everything in our lives and thrust it by necessity into the forefront of our community-based care. We have a number of speakers who will talk about the perspectives and or research on VR and stroke rehab, and questions will be left to the end. So I'd like to introduce first Denis Feltrin, patient or user of VR in Toronto, and he's at TRI, and he's going to provide us with a personal perspective VR after stroke during the COVID-19 pandemic. Denis, take it away.
Okay. My name is Denis Feltrin, and I'm happy to take the opportunity to talk about the pros and cons of virtual therapy. I had a stroke this year, January 7th in 2020, just after my 60th birthday. Little did I know that it was just the beginning of an incredible year that many didn't think that we saw coming. I began my medical journey at St. Mike's Hospital, where I spent 2 weeks before I transitioned to intensive care as inpatient at Toronto Rehab. This was followed by a month of fast track outpatient therapy till the end of March. My entry into virtual therapy started just at the beginning of the shutdown of in-person programs and the early days of the first lockdown. I continued to participate in speech therapy and physiotherapy and occupational therapy from home for 2 months subsequent to that date. Luckily, I've had the experience of various tech platforms in my work in financial systems, so I didn't have trouble getting online or get going. One of the biggest challenges I remember was having to tidy up to make my background presentable for logging into sessions. Let's start with the positive aspects of virtual therapy. I could do therapy from my home and without having to travel to the rehab center, saving me time and the expense of travel. It also allowed me to keep safely in my COVID bubble with family. The technology worked consistently with few glitches, and I felt that the ONT platform was secure in terms of privacy, and the therapist appeared comfortable using it right from the start. The camera allowed therapists to demonstrate what was expected, and they could see what I was doing in real time and provide feedback. This worked really well. Receiving therapy at home also had the advantage of working in a real-life setting. The stairs I worked on climbing were the ones I needed to navigate in my life. The railings were on the wrong side, but that was what I was going to need to use. It was very realistic and practical. The therapist could see what my living situation was like and make adaptations, such as moving a carpet or using different kitchen equipment. Some therapists provided YouTube videos for specific exercise to practice at home. This was super helpful as I could review them several times. Virtual therapy was also allowed my family to better support me in my therapy sessions, as they could see what the therapists were working on with me. Some of the sessions were by phone. This worked well for some, but it was not effective for other therapies. Challenges that may have been barriers to effective therapy were could be the lack of Wi-Fi, technology, or unfamiliarity with tech in general. I was fairly far along my rehab, but if I was in the earlier stages, it may have been more difficult to deal with hands-on support, which I needed. For example, when I was first getting back on my feet, learning to navigate stairs, stretching my hands, and transferring. Also, therapists could not see, but they could see but not feel my muscles and joints, for example, get the sense of tension, stiffness, or swelling. Virtual therapy might have also been less effective if access to specialized equipment was needed, such as bars, stationary bicycles, and harness to test my balance, and etc. Perhaps this could have been done with some home-style adaptations, but probably not. I think overall, I think that I had a lot of face-to-face therapy and virtual therapy. Virtual therapy worked well for me and came at a time in my recovery that offered an opportunity for me to continue and progress and refine my skills. It has been a long and challenging year for me and for my healthcare team, but I think we all have done well to adapt. Thank you for the opportunity of sharing my journey with you. Thanks.
Thank you very much, Dennis, for your perspective on VR after stroke. Our next speaker is going to be Patty Lindsay. Patty, most of you know, is Director of Health Systems Change at Heart and Stroke, and she's going to talk about stroke systems change post-pandemic. Patty?
Good morning, good afternoon, everyone, depending where you are. And thank you very much for having us and being able to co-host this session from Heart and Stroke this morning. And congratulations to everybody on having your at CPSR for your ASM today. So I'm going to kick off this follow-up from Dennis. Dennis, thank you for such a great presentation. You've brought up some really important points that I'm sure other speakers will touch on today. I'm using a virtual background just because, as you noted, having to tidy up the background is not something I was able to do satisfactorily this morning. So thank you for that comment. Okay, I will now move. I'm assuming I have drive slide control because it doesn't seem to be controlling. There we go. Okay, thank you. So I have no disclosures for this presentation. It has been 272 days, 6,528 hours, over 391,000 minutes, and 23.5 million seconds since March 16th, when we were all told to go home and stay home, and COVID was here for real. It's been a long journey. Many things have happened in the stroke system as a result of that, and I will just highlight a few things today. So when we talk about a system, we look at many different levels, including the leadership within the system, the environments, the organization, and individuals who are providing care or receiving care. And this pandemic, unlike others, have affected every single layer of the health system, and in profound and dramatic ways. You know, and it's not just been in acute care services or in rehab, but it's been across the entire continuum of care, and nobody's been left untouched. What we've learned quickly in the early days was that there was definitely some interactions with this virus with people with heart conditions, people with stroke. We were seeing early information about inflammatory processes that were not well understood, but clearly happening. Once some of the data started coming out of China and Italy, we found out that people with stroke were 3 times more likely to die if they had COVID versus those who hadn't had stroke. And for those with hypertension, which is the #1 risk factor for stroke, 2.5 times higher likelihood of not surviving if you got COVID. We know, and because of all that, preventing stroke, like really at the onset, preventing it from happening in the first place, is more critical than ever. And that unique challenges were posed that Dennis has just described around access to rehab, duration of rehab, intensity of rehab in this new environment. So just looking at some of those implications on the stroke system, physical distancing for many people with stroke who are already limited in mobility, it resulted in social isolation. You know, at the beginning they were using social distancing, and quickly, thankfully, changed that language, because physical distancing does not mean you have to be isolated. So really big efforts by Ontario Brain Institute and Alzheimer's and other groups to try to quickly address what we saw was happening. There was certainly reduced clinical services, in-person services became very, very minimal. And there was, as Bob said, we'd been trying to push for virtual care for rehab and prevention for many years, and we're making baby steps, and all of a sudden the door blew off. But people weren't prepared because we hadn't had a good lead-in prior to that. The good news is it's here now, and I'll talk in a few minutes about what we need to do next. So there was all kinds of redeployment of staff. So our staff expertise for stroke was pulled away to help with the COVID patients because they were highly trained individuals. And we had people caring for stroke patients who not necessarily had all of the proper training. And community services really reduced. We had conducted a survey of people living with heart conditions and stroke and vascular cognitive impairment in end of May, June, to understand what their challenges and worries were regarding COVID. And it was really fascinating. What you saw with some of the enablers was people were actually surprisingly more resilient and surprised themselves at how resilient they were, which was fabulous to hear. On the other hand, mental health was the #1 issue, both for people living with heart conditions and their caregivers. For the patient groups, access to any health services, and especially rehab, it was a theme that came out over and over again in the surveys, was a big issue. And it was almost equally as big an issue for caregivers. So what are the priorities for a stroke system to maintain services and not fall too far behind during COVID and during a pandemic and after? Education of everybody. People living with our conditions, the public, and our staff really need to be important, yet at the same time, time is so challenged right now that trying to find time for proper education has been an issue. So our networks have been monitoring the changes in the system at the provincial level and the regional level. Groups like Core Health, every provincial stroke system has been carefully monitoring and trying to adjust, trying not to lose ground on stroke. We've been more fortunate than some of our cardiac counterparts that there's been less procedures normally pre-scheduled for stroke, so less cancellations, but certainly around carotid artery elective surgeries and that there have been affected. EMS have been fantastic. The paramedics have been awesome with this, but they do have to take a few extra minutes to don proper PPE precautions, but they have really worked so hard to ensure that stroke patients are getting timely care. Everyone's had to relook at workflows, and rehab has really had to reinvent itself in many ways. And kudos to everybody in the rehab field for all the hard work they've done. So Heart and Stroke and the Canadian Best Practices did put out a statement during COVID on how to adapt and address, how our guidelines were affected, which ones you still need to follow the guidelines, but how to do it in an adapted way where necessary. So as Denis mentioned and Bob mentioned, virtual care, suddenly the door blew off, it got launched. But everybody kind of had their own path because we hadn't had the training, we hadn't had the processes and mechanisms in place. So different platforms, different models of telephone visual were happening. And people were getting there, but not necessarily in the same way and in the most effective ways. So Heart and Stroke's been working closely with people all over the country to help address some of these things, to do our part to support it. We're not direct care providers, but we certainly have been doing a lot of resource development and helping work with clinicians and people with lived experience. So just an infomercial, one of the challenges has been, how do you know virtual care is the right way to go? So if you immediately after this presentation today, we'll be doing an open house discussion, and we invite everybody to join us to really kind of tease this out a little bit more. So to implement virtual care, we have created a roadmap. It was actually a telestroke roadmap we already had that we brushed off and updated quickly. And many of you online were active participants in that, and we are so grateful to you. So we created some effective tips for clinicians on how to, in general, provide things to think about when you're delivering virtual care. And then in our toolkit we created, we go into much more detail and encourage you to look at that. At the same time, we worked with people with lived experience to say, what do you need to tell others? What should people know who are receiving virtual care, such as Denis? And Denis, I wish we had your input, but I'm going to call you afterwards. So we've been working on tools to help patients be ready for the care that you're going to be providing and to be effective participants. So that's a very rapid overview, because I was given 7 minutes, to introduce some of the work we've been doing and kind of set the stage for the rest of the presentations. Thank you very much. Back to you, Bob.
All right, thank you very much, Patty. My apologies earlier for some feedback. Just one reminder before we move to our next speaker that we will be having questions at the very end. If you could send your questions, there's a ask the question button on your screen. So if you push that, that question then comes to me and we will then feed that to the panel at the end. So just a reminder that we do have ability for people to present their questions, written questions, and then we'll try and get the panel to answer them. All right, our next speaker is Hélène Corriveau. She's a physiotherapist and professor at the Research Center of Aging at the University of Sherbrooke, Quebec, and she's going to talk about telerehabilitation for stroke. So Hélène.
So thank you very much, Mr. the Chairman. I'm very pleased this morning to talk about the telerehabilitation for stroke. I do not know I have potential for conflict of interest. First of all, let me define what I mean by telerehabilitation. Telerehabilitation is included in televirtuality, but refer more specifically to face-to-face rehabilitation session. That is a specific intervention and supervised exercise. The objective of my presentation is to share with you what we learned from the result of various studies of telerehabilitation before the pandemic, and that allow us to use this technology with more confidence. About 20 years ago, why telerehabilitation was considered? Remember, for stroke patients who were back home with residual stroke-related impairment, literature supported the need to organize outpatient rehabilitation services at home or other. However, most individuals with a stroke did not receive rehabilitation services because they live far from rehabilitation centers and services in rural areas were not available. The health system was not able to fill the needs. Thus, not all individuals receive equivalent rehabilitation services for stroke. So what we have learned from different studies? First, in terms of efficacy of telerehabilitation. The real question is telerehabilitation as efficient as face-to-face intervention? Because we know that therapists like to work face-to-face with patients. But it was important to understand if telerehabilitation at least as efficient as face-to-face. The different research design have showed that improvement with telerehabilitation is at least as comparable to that achieved in person. Positive impact was suggested on ADL, return to work, range of motion, walking, balance, pain, cognitive task, skin integrity, fatigue, confidence about falling, yes, quality of life, anxiety, and depression. Second, in terms of feasibility and acceptability of telerehabilitation, we have learned that patients are compliant with the exercise program or intervention if the therapy is properly delivered. No study, I said, have related adverse events during telerehabilitation sessions, such as fall. Therapists are very afraid that patients will fall during telerehabilitation sessions, but the literature does not report some falls. Telerehabilitation interventions are acceptable for both people with a stroke and their caregivers. But the satisfaction of the therapist in regard of telerehabilitation was mixed. We have to keep in mind that for clinicians and high contact with their patient, as well as hands-on therapy, it's how they have learned to treat patients before. Here is an example of the result of one of my studies on telerehabilitation, where we conducted interviews with 11 patients and 5 clinicians following an 8 weeks outpatient telerehabilitation intervention. All patients liked their intervention session and none dropped out of the project. Patients did not find it difficult to use technology. I have to say that we used a user-friendly technology where patients only had to turn on off the system. That's very important to ensure that enjoyable experience with telerehabilitation for everybody. And remember, this intervention method has the advantage of allowing users to receive services. From the therapist's point of view, in this study, therapists delivered telerehabilitation using 2 technologies. Intervention sessions were delivered using a desktop application, while the follow-up intervention were done using a tablet application. In addition of 1-hour individual semi-directed interview conducted by the research team at the end of each session, clinicians were asked to complete a short questionnaire about their experience with the technology on the desktop application. The questionnaire consists of 5 items of technical quality of teletreatment. It evaluated included reliability of the system, voice and image synchronization, refresh rate of the image, sound quality, operability of the peripheral, by example, the centimeters or the camera. And all we find in this research was helping to improving the system. As you can see before the pandemic, when you begin, some clinicians were not very satisfied with the technology when they begin. Satisfied vary depending on the type of technology used, desktop versus tablet, and other profession, physiotherapist versus occupational therapist and speech therapist. The PT prefer intervening with the desktop application and OT prefer to monitoring with the tablet. Physical therapists found it's very difficult to show their patient how to place the tablet to properly visualize the exercise. Speech therapists and OT find it's very difficult to make a full assessment with the desktop application. But for OT, even if the quality of the image and the sound were not all the time very good, at the time with the tablet, they managed to achieve their goal anyhow, to follow the patient and ensure that they were following the recommendation. Furthermore, OT found the follow-up with the table was great to increase compliance with treatment. Unfortunately, in our study, speech therapists were unable to follow up of their patient due to the lack of a human resource. So before the COVID-19 pandemic, clinician has the opportunity to ask himself about whether they should use telerehabilitation to treat their patient or not. As of today, this choice no longer holds because clinicians need to see the patient while following the current socio-sanitary rules. In fact, in 2020, there's a shift in paradigm, meaning how clinicians perceive telerehabilitation. He cannot come to see me. I will see him remotely. To help in their delivery of therapy, I would like to share a few tips for a successful implementation. From our listen that you have our research team on the research we did on telerehabilitation, the extract what we retain. First, safety as confidentiality is very, very important. Technology must be kept simple for clinicians to use, and the ideal situation is to have a super user who can troubleshoot if there's a technical issue. Also, clinicians must be well prepared for their therapy session because often they have to think about how to put the camera or how to teach patients where to put their tablet for an optimal reviewing by clinician. Also, clinicians have to think about alternative for carrying the evaluation of intervention by keeping in mind that the alternative intervention must follow established guidelines. And don't forget, small is beautiful. Telerehabilitation is a new field. In conclusion, rehabilitation is a suitable alternative. In a few years, we will have to remember that a pandemic may occur. Rehabilitation technology must be user-friendly, and a good internet services must be present in all the region. A technical problem has a major impact on the therapist's satisfaction. The biggest request for clinicians was when a technical problem occurs, a technician must respond quickly. Patients are satisfied with telerehabilitation and a therapeutic link can be established. Do not forget that patient satisfaction is associated to treatment compliance. Don't forget also that telerehabilitation allows high frequency, follow-up, and personalized intervention. In summary, when it's done right, meaning that a proper functional technology and the presence of a skilled clinician are combined, telerehabilitation is a promising alternative therapy to improve access to rehabilitation services. Thank you. And I want to thank you all my team, the Estrade equipe specialized in telerehabilitation at home. Thank you.
Okay. Thank you, Hélène. Thank you for sharing your research. Just to remember to everybody that if you want to ask a question, we have the Ask the Question button, and we will have some discussion at the end. Our next speaker is Brodie Sakakibara, who is an assistant professor of occupational science and occupational therapy at UBC, and he's going to give us the evidence that's out there on virtual reality post-COVID-19. So Brodie, go ahead.
So thanks for the opportunity to present today. Katie Farrell, thank you for the invitation. I've been asked to discuss virtual rehabilitation post-COVID, or more specifically, what has changed in the virtual rehabilitation landscape since the onset of COVID-19. I think COVID-19 has changed many things in virtual rehabilitation. Two overarching considerations that I'll discuss today are, one, that there's been a substantial increase in both the use of and interest in virtual rehabilitation from clinicians as a solution to provide rehabilitation while adhering to provincial and national orders of physical distancing to prevent viral spread. And as a result of this use and interest to provide virtual rehabilitation, combined with a desire and need to provide therapies that are supported by research evidence, COVID-19 really has detail. The increased use of and interest in virtual rehabilitation. We can look at a couple of surveys that were completed by rehab clinicians. The first is this COVID-19 Quick Canadian Physiotherapist Survey that was done by Izat et al. From the BC Primary Healthcare Research Network. Now, the purpose of this survey was to better understand the state of physical therapy practice in Canada during COVID-19 and understand how PTs are adapting their practice. This was a bi-weekly survey that started in May 2020, and they completed the sixth cycle, or the repeated measure, in August. Now, when asked how PTs are adapting their practice, as you can see on this figure here, many transitioned to virtual rehabilitation, albeit there was a slight decline over time and as the repeated measures were administered. In cycle 6 here, although a smaller sample, still 58% reported using virtual rehabilitation. And interestingly, 84% indicated that they'll continue using virtual rehabilitation after the end of the pandemic. Similarly, the Ontario Physiotherapy Association surveyed its members on their experience implementing virtual rehabilitation during COVID. Now, of the 365 respondents, almost all transitioned to using virtual rehabilitation. And what's interesting, and actually has important implications moving forward, is that the same percentage of respondents reported no previous experience with virtual rehabilitation. As well, 64 to 96% reported that they may or will continue using virtual rehabilitation post-COVID. And so these two surveys provide strong indication, I think, that virtual rehabilitation is firmly established in clinical practice, and that it's a model of rehabilitation that will continue to be used post-pandemic, either as a standalone modality or as a hybrid in combination with in-person therapy. And the prospects of this are excellent, I think, because then we might realize some of the anticipated benefits of virtual rehabilitation, recovery, improved accessibility for people with geographic and transportation barriers, as well as improved community-based rehabilitation and follow-up post-discharge. And so this takes us to the second consideration of virtual rehabilitation post-COVID. That being that there is a lack of research evidence in many areas of virtual rehabilitation, largely because clinical interest has raced ahead of the research evidence. And just to demonstrate, Hélène also presented a little bit of this review, but just to demonstrate perhaps the best evidence, I think, or the state of the science of virtual rehabilitation for stroke recovery is in this Cochrane review titled Telerehabilitation Services for Stroke by Kate Laver and colleagues from Australia. Now, what's nice about this review in particular is that it's a Cochrane review, and also it includes a meta-analysis of outcomes where there's sufficient amounts of evidence to combine. And also there are two versions, one that was originally published in 2013 and another updated version that was actually just published earlier this year. And so because we have these two versions, we can see how the evidence has changed over time. In 2013, there were 10 trials that were included for review. That included just over 930 participants. The studies were generally small, providing low quality evidence. Fast forward to 2020, the number of trials more than doubled, as did the number of study participants. However, what did not change were that the studies were still small generally, and the methodological quality of the studies were still low, unfortunately. Now, this review, they report on several outcomes but for the discussion today, I've just pulled a few outcomes that are representative of the findings in general. Now, when comparing virtual rehabilitation to in-person rehab, there was no difference in upper limb function, which is a good thing because this evidence demonstrates equivalence between virtual rehab and in-person rehab. But this finding, as you can see, is based on only 2 studies. And there was not enough evidence to look at differences in ADLs or lower extremity mobility outcomes. And the general conclusion in 2013 was that evidence is insufficient to guide practice and that larger, more adequately powered studies are needed. In 2020, the evidence has improved marginally. There are more studies focusing on similar outcomes for meta-analyses. And as an example, the authors observed no difference between virtual and in-person rehab in the areas of upper extremity limb function, activities of daily living, and balance. But again, as you can see, these findings are based on only a small number of studies. And the general conclusion in 2020 was that there now exists evidence that virtual rehabilitation may not be inferior to in-person therapy. But again, that larger, more adequately powered studies are required to provide more conclusive evidence. Now, while the evidence appears to be improving, there are actually a couple limitations to the results of this Cochrane review. And the first is that some of the interventions included for review might not be what you expect. For example, in the area of lower extremity mobility and balance, there are 4 studies in total. Most of these studies examined self-administered programs. So for example, a virtual reality program where a participant takes the program home and self-administers it, and there's minimal contact by a therapist. And so rather than the therapist delivering the therapy, in these cases, the therapist was simply checking in on progress. No study examined a synchronous program where a therapist was delivering an exercise program in real time with a participant using video conferencing. And so while evidence is improving according to these reviews, we still have to be cautious with the interpretation and actually question if the evidence is really improving for the type of therapy that we want to deliver using technology for certain outcomes. As well, another limitation to the evidence is that there are no implementation studies. And this is actually very problematic considering reports that upwards of 94% of physical therapists are interested or are using virtual rehabilitation, but they report no experience delivering virtual rehab. And so questions arise as to how to train therapists to optimally deliver virtual rehabilitation. And so while there is currently a lack of evidence, I think, this means that there's also vast research opportunities to fill those gaps. And I know there is much happening in this area right now, but just as a couple of examples, the Canadian Partnership for Stroke Recovery Can Stroke Recovery Trials research platform of 8 rehabilitation sites across Canada. Doctors Mark Bailey and Janice Eng will discuss this platform in more detail on Friday. This group has developed a program called Telerehabilitation with Aims for Lower Extremity Recovery, or TRAIL. TRAIL is a progressive exercise and self-management program delivered in real time to stroke clients. And Dr. Ada Tang from McMaster University and I are currently piloting TRAIL along with the Can Stroke Recovery Trials group. A second initiative is the Heart and Stroke Foundation has brought experts from across the country together to prepare evidence-based virtual rehabilitation guidelines or recommendations. And this initiative, led by Drs. Jennifer Yao from GF Strong Rehab Center in Vancouver and Dr. Nancy Salbach from the University of Toronto, will provide evidence-based recommendations in many areas of virtual rehabilitation, including recommendations for safety and privacy, eligibility of clients, training of therapists, as well as therapy and assessments. And so how has COVID-19 changed the virtual rehabilitation landscape? Well, there's been an increased use of and interest in virtual rehabilitation, and this use and interest will continue over time. But as a result, it has also exposed areas of virtual rehabilitation that lack research evidence. But again, at the same time, this has also presented vast opportunity for research to fill the gaps. And I'll just conclude on with this slide here. This was a comment made by Jennifer O'Neill. I don't know Jennifer. She's a PhD candidate, but I got this quote off the CPA, Canadian Physiotherapy Association website. And I think she sums it up nicely here. She says, speeding up implementation of this new virtual rehabilitation model of care and cutting corners due to urgency is not recommended. We must research, be diligent, and acquire the proper training and skills prior to launching such service. Overlooking these important steps could lead to poor quality of care, poor sustainability, increased fear of use from clients, and poor confidence from therapists, overall reducing the quality of rehabilitation in Canada. And I'll leave it at that. Back to you, Bob.
Okay, thank you very much, Brodie. That was great. Our final speaker is going to be Liz Inness. She's a physiotherapy PhD, lead with the Lead Mobility Innovations, or she's the lead mobility at the Mobility Innovation Center in Toronto Rehab Institute. She's going to talk about implementing telerehab in a rehab setting, their clinical experiences, and the development of an implementation toolkit. So Liz, go ahead.
Thank you. Thanks again for the opportunity to present. Let me just make sure I'm Yeah, just quickly, I need to acknowledge that I am speaking on behalf of a large team of individuals across our brain and cardiac rehab program that have been responsible for implementing telerehab at our setting, and I'm happy to speak on behalf of them and their work. So yeah, my objectives today were to bring some of the clinical experiences that we've had implementing telerehab in our stroke and brain injury rehab setting, and which led to the development of some resources that we've collated into a clinical implementation toolkit, which I'll also comment on. So the slide says, can you implement virtual rehab in 3 weeks? Well, the short answer is apparently yes, when you need to. Like many of our healthcare settings, our outpatient stroke and brain injury rehab setting pivoted completely to virtual rehab across a 3-week time period in March and April due to the COVID restrictions. So thinking about preparation and implementation, what did that look like for us in those early weeks? Well, certainly involved forming a virtual working group to lead the change, identifying implementation leads, and engaging our team in all of the planning. Gaining knowledge, so rapid reviews of the literature, what available resources, guidelines, and standards were out there, and consulting with both our internal and external experts. Developing our virtual model of care, so our professions were identifying what services could they provide virtually, and what did our virtual care pathway look like as our patients transitioned from the inpatient setting to the outpatient virtual care experience. Securing resources, so getting access for our staff to the telerehab platform, getting access to all the equipment that they may need, developing shared drives and online resources so that there was centralized access to resources amongst our team, and also a compilation of resources that could be easily shared with our patients. And of course, securing appropriate physical space in a setting that may not have been designed for virtual rehab. Provider training and skill development. There's lots of in-services with our staff regarding use of the telerehab platform and its various features on how it might support virtual rehab, technology troubleshooting, and shared learnings across and within our professions around implementation. Patient and caregiver education and training was also a key component of what we needed to do, and I'll touch on that again in future slides. And developing new processes. So who needs to do what now and when, and what what decision tools and forms do we need to develop to continue to support that implementation? So from those early weeks to now, it's been a process of continuous learning, of seeking out formal and informal feedback through our teams in various meetings, and also more formal through administering patient and provider experience surveys every 2 to 4 weeks to get that sort of real-time feedback and be able to respond to the needs in a faster fashion and continue to develop our practices. So I think just to touch on some of our learnings from the experience surveys, I think I'll give you the highlights because I think they echo what we already know. But of the patient experience and of those who participated in virtual rehab, about half actually found they had no challenges. And of the challenges cited, it usually related to use of the technology glitches, or having access to the equipment and space that they needed in their environment. About 7% had some challenges in actually participating due to physical ability, communication, vision, or fatigue, and a few did feel or had some challenges feeling safe during mostly the physical aspects of virtual care. However, the majority of patients felt confident to participate, and the majority also agreed or strongly agreed that the virtual rehab was meeting their goals. From a provider experience, again, some of the challenges that rose to the top, again, around the technology and the equipment, whether it be on the provider or the patient end in the environment. Approximately 30% of all of our sessions had some sort of technology challenges that may have required additional time or modifications. The healthcare providers had some challenges assisting patients remotely with the troubleshooting. There was additional time required, as was mentioned, for preparing, so scanning and emailing materials, worksheets, sending off video links to the patients in advance to prepare them for their session or to use during their session, as well as for follow-up. Virtual fatigue was a challenge that was mentioned. One of the key enablers of a few was caregiver support. And in our surveys, approximately 50% of all of our patients identified needing some caregiver support, either for technology setup or to actually supervise or assist in the remote assessments or therapies. And in contrast to the patient's experience, our providers had a mixed response as to whether they were meeting the patient's rehabilitation needs through virtual care, and citing it depended on a few factors: the patient's goals, the patient complexity or the severity of the impairments, and of course, their ability to access or ability to use the technology. And again, caregiver support was critical and sometimes was pivotal in terms of a successful or less successful session. They reported challenges in delivering some aspects of care, such as standardized assessments across a few domains, providing hands-on care, as has been already mentioned, and challenging the patient with specific safety concerns around balance training, outdoor mobility, and progressing aerobic exercise. And as we've moved into back to some in-person care, there's certainly some benefits cited for some individuals of having a hybrid model where there's flexibility in providing both virtual and in-person care depending on the patient's goals and needs. So from our experiences that I've just mentioned and our lessons learned, we've developed resources and processes that we've collated into an implementation toolkit. And I'll just provide a high-level overview of this. So what's in this toolkit? Well, the first section is on getting started. So it takes a quality improvement implementation science approach to this, provides some resources about identifying enablers and barriers in your local setting, some guiding questions to determine readiness, some helpful frameworks, and also has a section there on choosing the right technology depending on the patient's needs and the therapies provided. There's a section on preparing the patients and the caregivers. So some guiding questions to the healthcare professional to determine is their patient appropriate, and some information sheets to guide conversations with patients about making a choice, what to expect, privacy, safety concerns, what technology they may need, and caregiver information sheets. What is it that we're expecting of the caregiver to support that care, and what supports may they need to actually enact that role. Implementing virtual rehab is another section, and just to highlight some suggested processes on really supporting that inpatient, outpatient transition and handoff. Our virtual team finds it helpful in actually observing the patient prior to discharge if possible, sharing assessments where an inpatient discharge assessment may support and guide the virtual outpatient care, starting early with technology setup and virtual training with the patient in care and inpatient so there's less challenges as they're discharged home. There's some protocols and decision tools here, such as medical event protocols and decision trees around, what to do if a medical event occurs, and some pre and post-care safety checklists to support optimal and safe care. The last section is on evaluating and monitoring and some sample measures and links to patient and provider surveys. So my final slide here is really just to invite input. There's a link there where the toolkit is available at our Kite Research website. And it's the goal of our team to continue to develop this to meet end user needs. So if you do download it, we may follow up with you with a survey or invite you to participate in an interview, because we would really like to develop this to support some of the how-tos of clinical implementation to complement all the great work that's occurring around us. So I'll leave it at that, and thank you.
Okay, thank you, Liz. I think that was just fantastic. A nice combination from everybody of some of the research and some of the evidence that's out there and some nice pragmatics on people trying to actually now apply it. Our next step is we're going to move to a panel discussion, and some of you have sent in questions, so I'm going to ask different members of the panel different questions. So I'm going to have to just switch over here. There we go. And this is my, are we ready for the panel discussion?
Yes.
Okay. I can't see anybody because I'm on the questions, but the first question is for Dr. Corriveau. And the individual has asked, has there been a change in opinions on telerehab by therapists since the pandemic shut down and the necessity to switch to telerehab? So, Hélène?
Yes. That means if you, in 10 years, you will forget that probably you will have another pandemics. I think if we, like Liz and Brodie said, if we show how to treat patients, we'll still have good, the clinician will follow and they will use telerehabilitation. That's the question that it was, Bob. I answered the question.
The question was, has there been a change in opinions on telerehab? So the therapists think differently about it now.
Now it begins. But remember, I just look at the statistic that Brodie gave, that after, they said that after, only 64% will continue, physiotherapists will continue to use it. So I think right now, it's not still, they will change opinion. They change a little bit, but not really. You know why? It's because, and in the academic university, on everywhere, we don't teach right now how to use telerehabilitation, how to use the camera, how to use. So the physiotherapists, the occupational therapists, and the speech therapists now in this time try to use it, but they don't have all the skill to do that. But if you are able to just change, like Liz did in our hospital, to have a kit like Patrice have now, and the therapist reads the kits, read the guideline, and said, no, we know how to do that. Let's go. We know that. Okay. The research is not perfect, but we have to learn how to teach the clinician what to do and to the patient what to do. And it's for that, I think the guideline is very important. And the research is also very important to continue. And the research, that will be a problem. I'm a researcher and I began my research before the pandemic. And now I continue with the pandemic. And so I said, oh my God, because they change, but it's not perfect. I hope they will. But the therapists will be all the time important to be in face-to-face and hands-on therapy.
Okay, thank you, Hélène. My next question is for Brodie. Can you comment on the use of telerehab for rehab assessment and reassessment?
It's a great question, and something that further research needs to be done on to validate and to look at the reliability of some, particularly the physical and functional outcomes as part of that TRAIL study that I mentioned, which is the lower extremity recovery project. We had to modify a lot of our outcome assessments so that we can deliver it virtually. Before TRAIL we were going to implement TRAIL, and then all of a sudden COVID hit, and so we had to go back and revise TRAIL, as well as the way that we were going to administer the outcomes assessments. I think, if we're going to be delivering therapies using virtual technology like video conferencing, well, I think it's also important for us to develop assessments that can be done virtually as well. Because then what's the point in having the person come to the hospital or institution to do assessments and then send them back home for the therapy, and then have them come back to the institution to do another set of assessments. I think we certainly need to look at the reliability or develop some new ways to measure physical functional outcomes virtually to go to align with the virtual rehabilitation.
Okay. The next question just came in for Dr. Inness. I like this one. It says, can you provide examples of the types of therapies that work best for virtually, and those that work better when the patient has to be physically present? So are there some treatments that virtual reality seems to stand out as working best for, and some where it doesn't?
Mm-hmm. That's a great question. And I think it gets back to trying to decide that decision-making tool around, what patients are appropriate for virtual rehab. So I think Yeah, and I think there's flavors depending on the patient's goals. So if I speak to our speech language pathologists, they are actually loving virtual rehab and are able to do quite a bit of their assessments and care virtually. They love the fact that they're there within the patient's environment, and there's that transfer of as Denis mentioned, that transfer of goals right into the real environment. So some of the challenges, I think, are back to some of the physical therapies where you, as mentioned, need hands-on, maybe because of the patient's functional level or ability. Our therapists, though, have got quite creative in how to approach that, either modifying the environment for safety or for using the caregiver to support and supervise. You know, certainly there's aspects of care that might need some specific assessments, swallowing assessments, or, you know, exercise with ECG, where you might need to come in and do an in-person care. So I think, yeah, I think that there are certainly some hands-on care that might be more challenging virtual, but again, there may be some modifications that can be done to support that. I think certainly what our staff are also finding is as Brodie mentioned, the coaching and self-management aspect of virtual care has been a real positive. So although therapists may not be able to do some of the more challenging balance assessments or training that they might do, they're shifting into goals around self-management and coaching, and they're seeing sort of that self-management and transfer and occurring more so perhaps, and it sort of lends itself to that type of therapy as well.
Okay, thank you very much. The next one's for Hélène. It's a practical question. The individual is asking, for your statistics presented, what program was being used? Zoom, Skype? Because that individual has found that their experience with Zoom as it's not pleasant for clients.
Yes, we use our platform. We use the Terra platform. Is a platform that all my engineer work on this platform since 7-10 years. So we use the platform, and we modified a lot the platform to have the camera who can zoom the patient. And we have also modified all the system that when the patient have the tablet, we gave the tablet to the patient when he come back at home, and when he get the tablet is an on-off system. So it's very simple. And for the clinician, is able to just zoom what you want to see, and it can analyze. So we develop our platform, and since the COVID, everybody can use. If you want to have some information, the director of the chair who developed the platform ask if we can use, and so we can use the platform. Is free. So so that's for that it's better. I have a slide, I don't know, and we compare Zoom, we compare Skype with our platform, and we understand the clinician find it's better with our platform.
Now, what kind of tablet do you use, Hélène? That was another question.
It's a tabloid. It's not my tablet. It's not an iPad. It's a tablet, ordinary tablet that we use.
Okay. Ordinary tablet. What does that mean?
For the, I'm sorry,
iPad?
I'm not.
Yeah. Okay.
It's not an iPad.
No.
No, it's not an iPad. We don't use iPad. It's too expensive for the patient. So we use something very that we can buy a lot and send to every patient.
Okay. All right. The next question is, Brodie, what's your opinion on cognition sessions via virtual reality, especially with aphasic patients?
Cognition assessments?
Cognition sessions, so cognitive therapy.
Oh, cognitive therapy.
And especially with an emphasis on aphasic patients. There's a lot of worry about aphasic patients in the questions, but I think Liz sort of said that the therapists actually don't mind it. But I was wondering, they want to know your opinion on cognition sessions via VR.
Yeah, gosh, I'm not, to be honest, I'm not certain how to respond to that. I'm not very familiar with
Okay, anybody else? Liz,
therapy.
Hélène, Patty? Holy cow, you stumped the panel. All right, we're gonna move on. I got a question for Patty, and it's my question. What do you think is gonna be the future role of VR and telerehab when COVID eventually is brought to heel? What do you think telerehab's going to look like when COVID's no longer around?
I think from our perspective, we're going to push to keep it as an option. I don't think it'll ever disappear now because, to be honest, I don't think we're ever going to be virus free. So there's always going to, that's going to be one overriding piece. But I think now we finally gotten to where we wanted to be 5-10 years ago. And, I think what it's going to take, though, to keep it sustained is commitment at different levels. Federal government has made a statement that they will ensure, connectivity in all regions, especially the rural and remote regions. I think this has tremendous benefit in terms of increasing access and equity. But I've actually heard many people say it also runs the risk of widening the gap unless we address the issue of access to proper connectivity in those regions where we're supposed to be doing good. So, if we can get everybody coordinated, I know we're working on policy and advocacy statements to help push this agenda, but I can't imagine a world now where digital health won't be a part of it. And if we ever get back to that, it would be a sad day, because I think this has finally helped in a good way. If one of the positive benefits of COVID is it's finally helped push this particular issue, light years ahead from where it was, but actually still finally just catching up to the 21st century.
Okay.
Just to add on that, sorry, Bob, I think what we'll see immediately is a hybrid model where it's going to be a combination of virtual rehabilitation with the in-person, and then a continuation of virtual rehabilitation once people are back out in the community.
Yeah. It will be improving the services and the outcome.
Okay. Along those lines, is Dennis with us still?
Yes, I am.
Dennis, here's a question for you. Okay. If you had a choice, would you prefer virtual rehab or would you switch back to in-person if you had the choice?
My current goals are to get my hand and arm moving again, and I would prefer in-person.
Okay.
Yeah.
Can I ask Dennis a quick question, Bob?
Yes. Go ahead.
Dennis, thanks for your presentation there. I have a question. What was your, initial reaction to telerehabilitation when your therapist first offered it to you?
Well, it wasn't offered as an option. I really had to go and leave the hospital and go home, and so it wasn't an option. I could have had continued visits in person, but I had to go to a virtual scenario. Yeah.
Did you question it at all?
Well, COVID had hit, right? It was right in March, and my last session was it was March 22nd, and everyone was saying we're not going to be here anymore. So that was the challenge, right? So we had to leave, and my only option was to go virtual. So I was fortunate to have all the technology and everything else available to me, and it made it easy. And like I said, it was at a point in time where I had regained my balance walking, and my cognitive features were coming back, but and it was my arm that was the challenge, right? So we went back at that, but I still had so it was very much dependent on, and I was very helpful. It was thankful that we continued to have those virtual sessions, because we wouldn't have had anything if, because they said, you won't be having anything unless you stay on the virtual side. So that was my only option.
Sure, thank you.
Liz, the next question's for you. What criteria do you use to determine which patients are appropriate for VR?
Yeah, so we consider a few things. One is they're sort of guiding questions rather than a specific decision tree, but what are the patient's goals? And then sort of an interaction of that is what are some of the underlying impairments or complexities of that patient, and what services do they need, and then can they be addressed by virtual rehab? So it gets down to if it's return to driving and they need some high-level cognitive assessments, can they be done virtually or not? If someone's at a lower level of functional ability and there's safety issues, can they be done virtually or not? Or is the person at a certain level where coaching and self-management, etc., is important? So it gets down to goals, complexity and level of impairment, and then the therapies that are required to address those goals.
And Bob, in our next session, we're actually going to be presenting a decision framework, which Liz and others at TRI and many others have been involved in. So if people want to know more about that, come and join us in a few more minutes.
Mm-hmm.
Perfect.
And please, please reach out, and we have some of those questions in our toolkit. So if you want to download those or reach out to me, I'd be happy to share.
Okay. And then I've left this one kind of for last or second last, and I guess it would fall to Liz or even Hélène. Have you looked at the workflow for therapists? And does VR require more work outside of the session, but productivity expectations are the same? Somebody's a little worried that they're going to be asked to do more, but still do the same for less, as it were.
Mm-hmm. I don't know if I can give you specific numbers, but I certainly think the staff feedback has been, yes, there is some additional time that's required for preparation. So where our staff are getting a lot of the resources ready in advance and having to share those with the patients in advance, whether they're worksheets or exercise video links, so that the patient is prepared for the session. As well as I think more follow-up is happening around, here's that link and that thing that I want you to practice until we meet again, which is not necessarily a bad thing. But so I guess the feedback from our therapists is there's some additional preparation time that's required. I can't tell you how that, what those specific numbers look like in terms of workload.
Okay. Well, I think we're going to have to close it up. Farrell says we have to be done by 12:15, so we're going to be done by 12:15. I really want to thank the speakers, and I really want to thank you for the people who asked the questions. I thought it was a great session on a very topical area, and this ends this session of the conference. Thank you very much.